All right, so today's talk will be about men's health issues. So introduction of what a urologist is. So as urologists, we are surgeons. We take care of the urinary system for both men and women, but we take care of the male reproductive system. So yes, I spent a year in Tulane University in New Orleans, and you can see the picture here. This is my mentor, Professor Hellstrom. And yeah, so I did a clinical fellowship in andrology, male subfertility, sexual medicine, and urological prosthetic surgery. All right, so some of the surgeries that I do, like you mentioned, greenlight laser for prosthetic enlargement. This is a penile implant surgery, and this is me doing UroLift. Yeah, I also performed a live surgery at St. Luke's Hospital in the Philippines for a case of erectile dysfunction that we place inflatable penile prosthesis for. Yeah, so I also spend time giving talks to either the specialists, we give talks to the general practitioner and family physicians, as well as I'm also involved in public forums to talk to the public, to educate them on men's health issues. And also have the opportunity to be invited by the radio and some talk shows. All right, so I'm from a group called Advanced Urology. So we have 4 clinics in all of the Parkway hospitals. And my main practice will be in Mount Elizabeth, Orchard, as well as Parkway East. Yeah, and this is my email. If there's any inquiry, you can always email me after the talk. All right, so we talk about the problems with men. As mentioned aptly just now, men tend not to utilize healthcare resources. And as guys, we tend to be less compliant with following medical advice. And we tend not to focus on our health until something goes really wrong, because we always deem that a career and our own family, health matters, or any sort of financial matters or any other matters are more important than ourselves. So what are the real medical problems with men that are commonly seen? So there will be benign prostatic hypertrophy, that means the non-cancerous enlargement of the prostate versus prostate cancer. Men, as we grow older, we find that testosterone starts to drop, and should it cause symptoms, we would then seek medical attention. A lot of times, things like energy levels, we find it's not as good as before, or our sexual performance is getting poor. For example, erectile dysfunction. And of course, sexual dysfunction, when it now involves our partner, we tend to be concerned and we start to seek treatment, either because we think we need to be treated, or our partner actually tell us better go see the doctor. So today's topic, I'll just concentrate on 2 things: prostate enlargement causing urinary issues, as well as penile disorders causing issues in the bedroom. So the common factor in these diseases that I mentioned just now is actually aging. So first of all, where is the prostate gland? So this is a cross-section of the male pelvis. You can see over here, this is the penis, the testis. So the prostate sits right at what they call the bladder neck. So our bladder is the organ that stores urine and allows us to void the urine, that means empty the bladder, so that the urine gets expelled from the system. So the prostate gland sits right at the bladder neck, over here. So what's the role of the prostate gland? So the prostate gland is actually a sexual organ. So sperms are developed in the testicles, all right? And then the sperms will then travel along the tubes from the testicle along this tube called the vas deferens, which is the tube that we cut if a patient wants to go for vasectomy, all right? So the sperms will actually travel all the way up to where the prostate is, to gather the seminal vesicle, where it's nourished by the semen fluid. So the fluid that a man ejaculates, 95% in terms of volume, is actually from the prostate, as well as the seminal vesicles. However, the contribution from the testis is what makes a man fertile. Right? So looking at the urinary system, we have the kidneys, which is what I call the factory where urine is produced. Once the urine is produced in the kidney, it will then be transported by these 2 pipes. All right, the 2 muscular tubes called the ureters transfer the urine down to the bladder where it is stored. right? And then, like I mentioned, the bladder is both a storage organ as well as a voiding organ. That means wherever urine we produce, the last stop will be at the prostate, where it's a muscular bag. And once we have hit a certain volume, the body will tell us it's time to pass urine, and then we will squeeze the urine out through the muscles of the bladder, out through the urethra. And of course, the prostate gland actually sits right at the opening of the bladder, which we will I'll explain further what happens when the prostate enlarges. Yeah, so this is what happens during when the patient when he forms urine. So bladder is formed, urine is formed, comes down into the bladder through these two holes, which will then lead up to the urethra, like we've seen just now. Then once you have a sensation to void, usually the first sensation we can still hold. So for example, you're having a meeting, you have a sensation, but you know that you can still complete your talk before rushing to the toilet. Once it comes to a normal desire, you know that you probably have to end the talk and go to the toilet. So when you pass urine, what happens? The bladder floor actually relaxes, and then the bladder will squeeze the urine out. So as we are speaking right now, as you're listening to my talk, your bladder floor is actually contracted. That means in the restful state, the bladder floor is contracted so that you're not incontinent. So the prostate itself, we always talk about BPH, which is benign enlargement of the prostate, as well as prostate cancer, which every man is worried about. Please do understand that the normal enlargement of the prostate can coexist with the prostate cancer. So it means that if you have prostate cancer, it doesn't mean that you won't have benign enlargement of the prostate. Just like if you have a benign enlargement of the prostate, it doesn't mean that you will not have prostate cancer. So the role of the urologist is when you see us for any form of urinary symptoms, is you need to make sure, first of all, that the symptoms are not due to prostate cancer, but only due to a benign enlargement. Okay. So what happens when the prostate is enlarged? Like I mentioned just now, the prostate sits right at the bladder neck. So as it enlarges, you find that it actually compresses the urethra, and then it makes it difficult for the urine to actually empty from the bladder. So what are the symptoms that the patient will get when they have enlarged prostate? So because the bladder has two functions, we divide into storage versus voiding symptoms. So storage symptoms will be like feeling the need to go to the toilet all the time, making frequent trips. That's actually affecting our lifestyle. And the worst thing, waking up at night to pass urine. And in some cases, when the urge comes, some men actually leak. That's why I call urge incontinence. So other things will be voiding symptoms, hesitancy. For example, you go to the toilet, you have to wait before the urine comes out. And when it comes out, some men find that it starts and stops without, not within their control, what I call intermittency. And because of the slow stream, some of these men will then have to strain, to squeeze for the urine to empty. And some of them find that they can't completely empty the bladder and it starts to dribble towards the end of the stream, sometimes dirtying their underwear or even dripping onto their shoes. And of course, the worst thing, some patients are unable to pass urine, what I call urinary retention. Are these urinary symptoms acceptable as part of aging? I believe that we can't prevent aging, but we can always age graciously. So what happens if we ignore these, what I call lower urinary tract symptoms? Some patients can then present to us with blood and urine, what I call cross-hematuria, or even form bladder stones. The worst scenario, like I mentioned, some patients come to us with the inability to pass urine, and most of the time it is a painful retention. That means you feel that you have a full bladder, but urine just doesn't come out. So in those cases, most men will either present to the emergency room or to their family doctors first before getting referred to the specialist. So what happens if the patient is unable to empty his bladder? What the doctor will do, he will place a catheter, which is like a straw, that goes in through the urethra. That means from the opening of the penis, you can see over here, it goes all through the urethra and then all the way into the bladder. And basically there's a hole here that allows the urine to come out. And to prevent the catheter from slipping out, the doctor will then have to inflate the balloon over here with water, which is why a lot of patients, after being catheterized, although they feel some comfort in terms of abdomen being no longer so distended and painful, they still have the sensation to pass urine, although there may be no urine, because the bladder has this little balloon at the end of the catheter, which is being irritated by this balloon. So why do we want to treat benign prostatic hypertrophy or enlargement of the prostate? Because we know that if you leave things alone, what happens is the bladder will start to become thicker. Just like any muscle that you work out in the gym, it becomes thicker and what we call hypertrophy. But in the terms of, for the bladder, we don't want to have a muscular bladder. The reason being, the bladder is also a storage organ. That means it has to distend like a balloon. All right. So what happens if the muscle becomes really thick, the pressure inside the bladder actually increases. As a result, the pressure is then transmitted upwards towards the kidney where urine is produced. So we want to prevent bladder failure from setting in. Because once bladder failure sets in, there are no real medications that can actually reverse it. And then there are no good surgeries that can actually repair the bladder when the bladder is already failed. And once the bladder fails, the kidney will then bear the brunt because of the increased pressure, and then you end up with obstructive uropathy. That's something we want to prevent. All right, so what would you expect if you see a urologist in our clinic? So first of all, while waiting to see us, we usually will give you a IPSS score, which is a self-administered questionnaire. Give us an idea at baseline of what your symptoms are. Is it mild, moderate, or severe? There's also a quality of life score here. And then during follow-up, we will also administer this questionnaire again to see whether there's any objective improvement. So these are the questions that usually ask about incomplete panting, frequency, intermittency, urgency, weak stream, straining, as well as nocturia, which is waking up at night to pass urine after you fall asleep. So when you see a urologist, this is something that cannot be avoided. It's what I call a digital rectal examination, because the prostate can be assessed through the rectum, which is a rear passage. So the urologist will using a gloved hand, which is lubricated with gel, you actually feel the prostate. The reason why we want to feel the prostate is to feel for any hard nodules that's more suggestive of prostate cancer. We also want to have a sense of the anal tone to rule out any neurological problems, any problems with the nerves. And in our clinic, we usually will do a bedside ultrasound. So we will quickly do an ultrasound of the important organs in terms of urinary function. We will make an ultrasound to look at the size of the prostate and the configuration of the prostate. We look at the bladder, looking for stones, looking for any abnormal findings, for example, things like bladder tumors, because bladder tumors can also present with urinary symptoms. And we also want to have a quick look at the kidney to make sure the kidney is okay. There's no signs of obstruction, no signs of stones. And we usually advise patients who see a urologist to come with a full bladder, so we can do this test called the urine flowmetry. So we have a room in which the patient will just pass urine into a special machine, and the machine will be able to generate a graph. So from this graph, we'll be able to tell, for example, how much you've voided and the maximum flow rate. And we also look at the shape of the curve, give us an idea whether it's due to any form of meaningful obstruction that needs to be treated. Then after passing urine, we actually do a bladder scan to see how much urine is left in the bladder to assess whether you're able to empty the bladder or not. And in some cases, we may need to do a flexible cystoscopy. Basically, this is done under local anesthesia. We clean the area, we put some gel, and we slide the scope in. Basically, we want to visualize the urine tube called the urethra. We want to visualize the area where the prostate is, right at the bladder neck, to look for any enlargement. So this is what a typical enlarged prostate will look like. You can see two what I call the lateral lobes. Sometimes you can see that they're growing inwards towards the urethra and causing obstruction. And we look inside the bladder to look for any signs of trabeculation, which means that whether the muscle is actually thickened. We also want to look for things like stones and to make sure there's no tumors. All right. And this is a view of what I call a recurve view. We actually look back at the bladder neck. So basically, the scope goes in, we turn around and see whether the bladder neck is being obstructed by the prostate also. Okay, like I mentioned just now, and anyway it comes to us with urinary symptoms, we think it's due to enlarged prostate, we want to make sure it's not cancer. So what are the prostate cancer tests that we do? The common test that's done, which is a blood test, it's called prostate-specific antigen. All right, so we usually take the cutoff as 4 nanograms per deciliter. A raised prostate-specific antigen does not always mean it's prostate cancer, but it's one of the causes. So other things like if you have a very big prostate, you tend to produce more PSA also. If there's a urinary tract infection, PSA will be raised. If there's a recent instrumentation of the urinary tract, for example, catheterization, like I mentioned just now, or even a scope, It can also cause the PSA to raise. Basically, anything that makes the prostate too excited causes the PSA to enlarge. So, for example, recent ejaculation in the last 48 hours can also raise the PSA. So, because PSA is so non-specific, another blood test that we will do will be a prostate health index. So the patient is the same, it's just the same blood draw, but we have other calculations to give us a risk stratification. So the PHI can stratify the patient into low, moderate, or high risk. However, the PHI is still unable to tell the doctor and the patient that, okay, this patient does not have prostate cancer. So previously what we used to do is if we examine the prostate, if it's normal, like I mentioned just now, hard nodules, we'll go ahead to a biopsy, with or without a raised PSA. If let's say the digital rectal examination is normal, the PSA more than 4. When I was in my training years, we just go straight to a biopsy. But we find that a lot of times we do biopsies and the results do not come back as showing any cancer, and the patient has actually undergone a procedure, and some of them have the risk of infection and bleeding, which we are trying to reduce. So what happens? So this is how the biopsy is being done using transrectal probe. We usually do it under sedation, so you will not feel anything. So now, because the reading of MRI is so superior, we are actually able to fuse the images of the MRI together with our real-time ultrasound so that we can biopsy the areas that is picked up by the radiologist to be suspicious. This is to increase the yield of the biopsy so that the patient doesn't go for a biopsy and then we actually decrease what we call the chances of false negatives and false positives. So basically, this is what it looks like when the radiologist identifies the area of concern. They will actually mark it out for us, and we have the software, this system called NeuroNet, where we can actually target exactly where we want the biopsy. So basically, the MRI images are fused to our real-time ultrasound images, and we can then localize. For example, if we think that this is the area where there's a chance of it being cancerous, we can actually target it so that it's what I call a lesion-directed biopsy. And after the biopsy, we're able to generate images to show you like where our biopsy areas actually landed. At the same time, we still perform standard biopsy calls, usually out of about 12 calls, to make sure that we don't miss out any cancers. Because previously, what we used to do, we only had standard biopsy calls. So you can imagine now, because of the improvement in technology, we can, other than doing the standard biopsy calls, we can do targeted biopsy at areas of suspicion. So the chance of picking up cancer will be actually more accurate. So what about the treatment of the enlarged prostate? Back to the non-cancerous part. We have medications that actually improve flow as well as shrink the size of the prostate. So medications that improve flow are called alpha blockers. These two medications are commonly used. And medications used to shrink the prostate size will be this medication called LiESWT, which actually alters the hormones. Then there's also surgery, and then recently minimally invasive treatment, which I'll explain more as we go along. So the medical treatment, alpha blocker and 5-ARIs. So we know that 5-ARIs have a longer lasting symptom benefit. It shrinks the prostate. However, this is only useful for patients with enlarged prostate more than 40 grams. Right? Alpha blockers usually work relatively quickly. It relaxes the bladder neck to help the patient to pass urine well. And we find the combination therapy is still the best. But the problem with these drugs is they do have some side effects that younger sexually active men may not be able to accept. Okay, so over here, this is the shrinkage of the prostate. It shrinks prostate by these 5-ARIs. The alpha blockers prevent the activation of alpha blockers as alpha receptors. As a result, there's actually relaxed smooth muscle. So the bladder neck is actually relaxed. Okay, so some issues with these oral medications as such. Although it works relatively well, but there are some patients who find that they have giddiness due to drop in blood pressure when they get up too quickly from a lying down position, what I call postural hypertension. Because of the fact that the bladder neck is relaxed so well, some men find that the volume they ejaculate actually less. And in some patients, they don't even ejaculate at all. With those patients who take 5-alpha reductase inhibitors, because it works on the hormones, they end up with erectile dysfunction. And in some patients, even gynecomastia, which is breast tissue enlargement. We're doing all treating the patients, like I mentioned, giving all these medicine just to prevent what we call urinary retention, so that the patient does not have to be catheterized. But sometimes, as the condition worsens, once the prostate grows to a certain size that the medication is unable to work, the patient may come to us for urinary retention. So when should a man consider surgery, men with enlarged prostate? So if the patient has kidney failure due to blockage by enlarged prostate, like I showed you early on in the pictures, or if you have retention of urine requiring placement of catheter, which cannot be removed because he's unable to empty his bladder well, if there's a continued bleeding due to enlarged prostate, if the patient has repeated urinary tract infection with or without a catheter, patients who actually develop stones actually shows that the bladder function is actually compromised. Yeah, the residual urine is very high. That means the urine left in the bladder after each is so high, it's forming stones. These patients should consider surgery. At the same time, we will remove the stones and deal with the obstruction. Of course, the other group will be patients who find that after taking medication, the symptoms are still bothersome, or patients who are unable to tolerate the side effects of the medication, either be postural hypertension, or in younger men will be things like sexual dysfunction. So they did this survey, and we find that 8% of men who wake up in the middle of the night because of enlarged prostate actually finds it's bothersome. But we tend to forget that the partner that's sleeping next to him, every time he wakes up, actually these women are affected by the fact that a man needs to wake up to pass urine. So a lot of times, treatment of BPH now is more swinging towards the couple rather than just treating the man, because we know that the poor wife is, or girlfriend is being affected because of the fact that the guy keeps waking up to pass urine. So the surgical options available will be TURP and TUVP. These are the common surgeries that we do. So TURP, we call it resection of the prostate. So what we do is with the patient under anesthesia, we pass this metallic scope, which we call a rigid scope, pass it in, and then we're using an electrical knife, also known as diathermy, we actually shave the prostate. So it's almost like we are actually coring an apple. All right, so the prostate is enlarged. At the end of the procedure, you have a good channel. But the problem with doing this surgery is that we will definitely have to cut into the bladder neck. And as I mentioned just now, the oral medications help to relax the bladder neck so well the patient can't ejaculate. So in these cases where the bladder neck is actually cut, they definitely will not have any more ejaculation. All right. Most of the patients will need a catheter immediately after the surgery. They stay up to 1 to 2 days, and we always try to remove the catheter before the patient goes home. In some patients who are unable to pass urine immediately after the surgery, we'll put in a catheter again and wait for about 2 to 3 days. And most of the time, they're able to pass urine. And we'll be passing urine at a really good rate. That means they're able to pass urine really well and empty the bladder most of the time. However, like I mentioned, there will be no more ejaculation after the surgery. All right. So other than using electrical knife for diathermy, we also use a greenlight laser. So only difference is that greenlight laser, we vaporize the prostate, which means that there's no tissue. Okay, so vaporization is very good for those patients on blood thinners, especially those with heart problems. For example, if they have a stent put in, the cardiologist starts them on these blood thinners, which cannot be stopped for medical reasons. Patients who already have underlying clotting disorders, also a good group of patients that actually would benefit from this technology. All right, there's usually a need for catheter after the surgery, and most of them can either go home on the same day or the day after. We try to remove the catheter before the patient goes home. Same thing, there's no more ejaculation after the surgery. All right, this is what picture of what it looks like during the surgery. So TURP, basically we are using electrical loop. You can see when it bleeds, we can just stop the bleeding at the same time. So there is tissue. This tissue will then be sent off to the pathologist to look for any cancer cells. However, look at green light laser. Basically what I do is that the laser actually vaporizes the prostate. It just burns everything, just like Star Wars, right? So it burns everything. At the end of it, what you're trying to achieve is an open channel. And like I mentioned, the downside will be the patient will not be able to ejaculate after the procedure. So the aim of TURP or TUVP, when I tell my patients, is that, for example, currently because of the fact that your prostate is so big, you're like walking down this narrow path. So what I'm trying to achieve is to create it into a 5-lane expressway so that the urine comes out nicely, and hopefully you'll pee like this gentleman over here. But of course, like I mentioned, sexual dysfunction, which is the most common, is retrograde ejaculation. So you can see over here, During ejaculation, bladder neck closes, the semen should come out straight into the penis. But once the bladder neck is disrupted, the semen will actually go in the path of least resistance, goes into the bladder. It doesn't harm you in any way in terms of health. It's just that when you ejaculate, it's just dry ejaculate and dry orgasm rather. There's no ejaculation that comes out. Some patients also found that they have erectile dysfunction after TURP because of the currents that's being transmitted during the procedure. But this is relatively rare in terms of TURP causing ED, but it has been reported also. Okay, so the survey has been done and find that 86% of men have actually said that preserving sexual function is an important factor when considering a BPH treatment. And we used to believe that, okay, just to improve our urinary system, we have to give up our sexual function. But is it true now? I don't think so. Because we find that now that we understand BPH so well, a lot of patients are actually coming forward when they have early BPH. That means they're having symptoms that they find bothersome. And a lot of these men who are still sexually active will not be able to accept sexual side effects. And some patients are not also not keen for long-term medicine. Most men do not like to take medications for a long term if possible. Or if we talk about TURP and PUE, they find that they are not ready to actually give up sexual function. So in comes the minimally invasive procedures. So these are currently the 3 procedures that are available in Singapore: UroLift, ProLift, and Zoom. So ProLift basically is microwaving the prostate. They use a catheter that's placed into the urethra, into the prostate, and then using energy, actually melting the prostate. All right, this is a probe that you need to put in the rectum, basically to measure the temperature, to make sure that the temperatures are actually performed, and the procedure to perform under safety precautions. This is a clinical procedure. However, there are still some reports of sexual dysfunction like retrograde and ejaculation and erectile dysfunction. And if the prostate is too big, ProLift may not be a good idea. What about Resume? Resume is known as steaming the prostate. So ProLift uses microwave. Resume uses transurethral water vapor therapy. Basically, they're using water vapor to steam to kill the prostate. So this is what the machine looks like. So the instrument is actually placed inside the prostate and it's fired in, and then steam is actually pushed into the prostate to melt the prostate from inside. However, the problem with Resume is that you need to place a catheter for at least 5 days. And usually Resume is also targeted at smaller prostates. And we find that most men with smaller prostates would not have presented with urinary retention. That means they would not have needed a catheter to begin with. So doing a procedure where the patient doesn't have a catheter, and then they need a catheter for 5 days, I find it some men very difficult to accept that, because it may affect their daily activities of life. And sexual dysfunction is still being reported in these group of patients that undergo Resume. So for myself, I tend to do UroLift. I was first introduced to UroLift during my fellowship days, and I was really excited. And it took many years before the Uro actually reached our shores. I've been fighting really hard to get people to bring it in, and really glad that we started doing UroLift since last year. All right, so what is UroLift? UroLift is basically you can think of it like pulling the curtains apart of your window. All right, so you can imagine if, let's say, these are the prosthetic lobes, you pull it apart, then it opens up the channel to allow the urine to come out from the bladder neck. There's no damage of tissues at all. So like I showed you just now, this is what an enlarged prostate looks like in a scope view. So after placement of UroLift, all right, so we actually push it apart, and then you can see it's a nice, what we call an anterior channel, which is the channel from the bladder out into the prostate. And this allows the patient to pass urine well. So I placed the first UroLift at Mount Elizabeth Hospital on 16th of October. And I'm currently being accredited by the company to perform UroLift for patients independently. So this is what the UroLift machine, or rather the delivery device, looks like. Basically, you have a permanent implant, which is a suture with 2 tabs. So we use a smaller scope compared to what we use for TURP. It's much slender. We slide it in with the patient under sedation. There's no need for general anesthesia. It takes about 15 minutes to 20 minutes for it to be done. So what I do is I'll push the prostate apart, fire it in. So you can imagine when you fire out, one of the taps catches on the outside of the prostate, and then we cut the suture with this proprietary device and place the implant on the inside. At the end, what you have is a prostate that's being pulled apart. There's no damage to the tissue. We do not remove any tissue at all. Just like I mentioned, that's what it looks like. So if you compare UroLift to medications and other forms of surgeries, TUMT, which is a ProLift, tuner is a needle ablation, and resume. In terms of erectile dysfunction and sexual dysfunction, like ejaculation dysfunction, is 0. All right, so there's something I find will be beneficial to men with a prostate that's not too enlarged, but the symptoms are bothersome enough for them to want to seek treatment, and they cannot accept either taking long-term medications or they cannot accept the sexual dysfunction associated with other forms of treatment. So this so far is my outcomes versus the 1-year LiESWT study. Basically, the 1-year LiESWT study is the gold standard study for UroLift when they first started it. So the company will actually plot the curve for us to see how we are, how our patients are doing. So far the outcomes for my patients is quite close to the 1-year LiESWT study. It's something really encouraging. So why do we do UroLift? So UroLift is a day procedure, like I mentioned, takes 15 to 20 minutes, at most up to half an hour, done under sedation. Most patients don't need a catheter immediately after the procedure. So as you can remember, TURP, TUVP needs a catheter, resume needs a catheter. Some patients with ProLift may even need a catheter after the procedure. All right. So for UroLift, most of my patients do not need a catheter. There's definitely preservation of sexual function, and the medications can be stopped after the procedure. All right. Yeah, moving on, the last topic will be on male sexual dysfunction. Okay, the common sexual dysfunction that men face will be things like erectile dysfunction, premature ejaculation, as well as penile curvature. I will focus my talk more on erectile dysfunction and a little bit on Peyronie's disease. So we used to call erectile dysfunction impotence. When I was a medical student, I remember using the word impotence. The problem with labeling a man impotent will then actually cause him not to come to see a doctor, because saying that it's impotence shows that he has totally no potency, and that has a negative connotation. So we find that when we change the term to erectile dysfunction, it sounds more I'll say it sounds more scientific, and more men are then willing to share that they have issues in the bedroom. All right, we know that erectile dysfunction is no laughing matter, and what does it mean? So erectile dysfunction, if you ask for the definition, it will say it will be a persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. When the patient comes to see us, we try to ask questions to see whether it is a grade 1, grade 2, grade 3, or grade 4 in terms of erection, how hard the penis is. So of course, the gold standard will be grade 4, all right? And most patients that come to us, those who are really more severe patients that come as grade 1, but most patients come as a 2 or 3. Nowadays, we see more patients with grade 3 partners coming because they can have intercourse, but they find that it is not as satisfactory for either himself or the partner, and he wants to improve his erection. So what happens during an erection? All right, if you take a cross section of the penis, we have 2 muscles here, not the cavernosal bodies, which is a spongy tissue, and at the bottom is what I call the spongy corpus spongiosum, where it's the urethra. So you can remember just now, the urethra leads upwards to the prostate and the bladder. This is where the urine and the semen comes out. So what happens during erection? When the patient is aroused, the brain sends down signals through the nerves, and the blood vessels will then dilate. That means the blood vessels open up and blood rushes in. As a result, the penis becomes longer and harder, and the outflow, which is called the veins, are actually compressed. So the blood actually stays inside the penis until the man ejaculates and reaches orgasm, and then it goes into the refractory phase where the blood will then be drained out. So for men with erectile dysfunction, it can either be an inflow issue or outflow issue. So inflow issue may be due to men who are smokers, diabetics. The blood vessels are all blocked, what I call atherosclerosis. All right. In younger men, it tends to be what I call an outflow issue, which is called venous leak. So these men are actually too A lot of them find that because of a single episode of unsatisfactory erections, the next time they try to intercourse, they are worried. So once a man is worried, he gets into a state where the adrenaline actually picks up. Too much adrenaline actually draws away the blood because the body then shuns the blood away from the penis to the more important organs like the kidneys and the brain. So in those patients, they can be due to venous leak. Of course, there are patients who have both inflow and outflow issues. Okay, so erectile dysfunction, especially in young men, is not merely a sexual problem. We find that it can be an early sign of cardiovascular disease because, like I mentioned, it's due to the vessels being blocked. All right. So what do we do when the patient comes to us with erectile dysfunction? We start with lifestyle modification. If the patient is smoking, we encourage to cut smoking. Alcohol, not too much, because if the alcohol levels are too high, you actually decrease your ability to respond to a sexual stimulus. Cutting down on the weight, good exercise, and a healthy diet is also something that's necessary to improve your erections moderately. All right. We know that some men will have low testosterone, and they will also present to us with erectile dysfunction. So other than erectile dysfunction, other things that the patient will have will be decreased sex drive, and decreased energy, and the loss of morning erections. And we may test the testosterone levels, usually in the morning, and then if it's documented as low, we will then treat the patients with testosterone therapy. So this is an example of all the symptoms of testosterone therapy. It can be relatively non-specific, but the most common will always be sexual function that's being affected. All right, so there was a study done to show that what kind of symptoms you expect at what levels of testosterone. So the common treatment options for testosterone, we have oral tablets, we have topicals, and we have injectables. All these have to be prescribed by the doctor. We usually discourage patients to buy from the internet because we don't know what it contains, and there's always a risk of harming your health, and you don't know what it contains. We've even had cases previously in Singapore where the patient actually bought those street-side medications and ended up in the ICU. So this is what we call the T trial, the testosterone trial. It is shown that in terms of sexual activity, by replacing the testosterone to the normal range, all the patients reported improved in terms of their sexual function. Non-surgical treatment options will be medications, PDE5 inhibitors. We have injectables, where the patient injects before intercourse, as well as what we call adjunct therapy, where the patient uses a vacuum erection device to draw in the blood, and then using a plastic ring, putting at the base of the penis to prevent the blood from escaping. So PDE5 inhibitors, they are not aphrodisiacs. It's a prescription medicine again. Patient needs to be aroused before the medicine will work. So we always tell our patients, take it before intercourse, and there must be foreplay. You cannot just, the couple can't be sitting there waiting for the erection to come, because that's not going to happen. Patients with heart problems on certain medications that contain nitrates are not suitable, because if they have nitrates and they take these PDE5 inhibitors, the blood pressure will drop really tremendously, and then it can result in a heart attack and stroke. All right, so for PDE5 inhibitors, we have the long-acting, the short-acting, and a second generation, which works within 15 minutes. Intracavernosal injections is self-administered by patients before any sexual activity. So the difference is intracavernosal injection does not require the patient to be aroused. So even if he's not aroused, then he will still see some effect. The blood will still rush in. Of course, this is more for patients who either have failed oral therapy or they are contraindicated to taking the oral medicine. Vacuum erection device, like I mentioned, drawing in blood is what it looks like. This cylinder is translucent for a reason, so they can see the penis. By activating the pump, it actually sucks in the blood. And once the patient finds that the size of the penis is relatively okay and he thinks that it's hard enough, he slides down the ring, preventing blood from escaping. And of course, after sex, they must always remove the ring. If not, you'll totally cut off the blood flow to the penis and you can damage the penis. Recently, we've been doing things like shockwave therapy. So basically, in a way, we're shocking the penis back to life. So shockwave is something that us urologists have used very often. We started with the high-intensity shockwave for breaking of stones. Orthopedic surgeons use it for those anti-sopathies, that means pain in the joints as well as tendons. The cardiologists use it in the early 2000s and found that after shocking the heart, there was actually increase in terms of the blood vessels, what we call angiogenesis. So there was this Professor Vardy from Israel, who decided run a trial to use it on the penis. So how do we perform it? We actually shock the penis about 5,000 shocks along the penis. And what it does, it causes generation of new blood vessels. So as to improve the blood flow to the penis and improve the circulation. And recently it's even found that there can be regeneration of nerves after a patient undergoes a shockwave treatment. However, the true cure of erectile dysfunction at this point in time is still the placement of penile prosthesis. Basically, there are two types, A, which is the malleable, and B and C, which are the inflatables. So basically, we put two rods into the cavernosa body that I showed you just now, one on each side. For the malleable rods, the patient will have stiff penis all the time. So when he wants to have intercourse, he points it straight. When he doesn't want the intercourse, he just points it up or down. B and C are the ones that's inflatable. That means they can deflate because you can inflate it, right? So when you deflate it, the penis will be soft. When the patient wants to have intercourse, he reaches down to the scrotum, presses the pump, and the saline or the salt water will then go from the reservoir into the cylinders, and the penis will be hard enough for penetration. And the patient can allow the penis to be as hard for as long as he wants, because even after he ejaculates, you find that the penis will not go soft because of the implants that should be placed inside. Okay, this is what the malleable rods look like. And this is what the inflatable, there's a 2-piece versus a 3-piece. So how do I put it? I usually go by the penoscrotal incision, make a small incision here, and then I'll insert everything in through this small incision. And I find that this is aesthetically usually better because it hides the wound and the patient has less pain. Some doctors actually do infrapubic, which can still be done. However, we find that infrapubic, we are worried about injuring the nerve. As a result, the sensation of the penis may be altered. So what does it entail? It's a day surgery procedure. Some patients go on the same day. Most patients stay overnight because of the catheter. We usually leave the catheter in overnight, and then I'll wrap it up like a nice present. The next morning, I will remove the catheter and remove the dressing, and the patient will then be instructed how to use the implant 6 weeks later. Moving on to the last topic of penile curvature. Some men are born differently. From young, they find that the penis curves. That's why I call congenital penile curvature. The other thing would be what I call Peyronie's disease. Peyronie's disease tends to occur in men above the age of 40s to 50s, where the penis starts to curve in either upwards, downwards, or to the left and right. Congenital penile curvature, like I mentioned, it is something that's been there since young. Treatment can only be surgical correction. Usually, if the curvature does not cause any discomfort during intercourse, most men will not present. And if you look at Peyronie's disease, it is what I call a wound healing disorder with scar formation. A lot of men come to us because they feel the scar. They are worried about this nodule that they feel on the penis, most commonly on the top of the penis, along the shaft and the mid shaft. They feel a nodule. They are worried about cancer, right? And we know that with this healing disorder, the curvature can get worse with time, as a patient can have progressive penile shortening. And we know there's this thing called acute versus chronic phase. Most of us will only offer any form of surgery in the chronic phase, I mean 6 months after the onset of the disease, because that's when the disease actually stabilizes. Treatment ranges from oral therapy to penile traction to surgical correction. All right, so something like this is what I call a plug. So you can imagine, because of the scar, the penis is unable to straighten, because when the blood rushes in, it's actually pulled up due to this scar formation. Some patients have it on the left, or on the right. Some patients have it right in the middle. All right. So does it mean that you have a penile curvature, you have to be straightened out? Usually not, unless you find that there's difficulty with penetration affecting the relationship, causing pain to partner, causing pain to himself, affecting sex life and relationship. Then we should actually straighten things out so that the relationship will not be compromised because of the fact that the penis is not straight. All right, so I'll come with some take-home messages. Yeah, so we know that any form of urinary symptoms should seek medical attention, because we know that untreated BPH may lead to kidney failure. Medications definitely can help to a certain extent. TURP and TUVP, those procedures like I mentioned, are still good in terms of symptoms. However, we know of the sexual side effects these days. And UroLift is a good option for men who want to preserve their sexual function. And a trip down to the urologist's office in the early stage of this disease will definitely preserve the kidney function and possibly even the sexual function. And we know that erectile dysfunction is treatable. Shockwave therapy can potentially help shock the penis back to life, and penile implants need no longer be reserved as a last resort, as every man is different. So depending on what the patient wants. If the patient wants something that works relatively quickly, there's no need for him to go through everything like taking medications and all that. He can consider penile implant. We can accept the risk of surgical risk, for example, infection and all that. All right. And of course, for the best results in terms of the penile prosthesis, you should consult a prosthetic urologist before we discuss this placement.